For centuries, the heart has been the symbol of love. In songs, in stories, in poetry, a racing heartbeat means passion, a broken heart means grief. We've grown up believing this small organ holds our deepest emotions. But how much do we really understand the heart beyond the metaphors? Because just like the brain, the body's most complex organ, lives another tireless marvel. An organ that beats over 1 lakh times a day without rest, without pause, for an entire lifetime. In recent years, we've all seen the unsettling headlines.
Kannada actor Puneeth Rajkumar passed away this afternoon after suffering a heart attack earlier in the day. He was just 46 years old. Puneeth Rajkumar was immediately rushed to the Vikram Hospital in Bengaluru, even as his condition turned critical. At the same time, he was non-responsive when he was brought to the hospital. The doctors tried very hard for resuscitation, but unfortunately, he lost his life in the afternoon.
Young, seemingly healthy people collapsing without warning. Sudden cardiac arrest, silent arrhythmias, electrical storms within a muscle we thought we understood. So, what really happens when the rhythm of life falters? Is the problem in the plumbing or in the wiring? In this deeply moving conversation, neurosurgeon Dr. Sharan Srinivasan sits down with cardiologist and electrophysiologist Dr. Venkata Krishna, a specialist who studies the heart not just as a pump but as an electrical system governed by signals, circuits, and timing. From ECGs to cardiac MRI, from ablations to defibrillators, from syncope to sudden cardiac death, this episode explores how modern medicine listens to the language of the heart to save lives. But this is also a story beyond medicine, a journey shaped by resilience, purpose, personal loss, and faith. Two surgeons, two organs, one conversation about life, mortality, and what keeps us all going, both biologically and spiritually. This is Rebooting the Brain, and today we are understanding the rhythms that sustain life itself.
Jnananandamayam Devam Nirmala Spatika Krutim Adharam Sarva Vidyanam Hayagriva Upasmahe Hayagriva Upasmahe.
Rebooting the Brain, powered by PRS Neurosciences. Namaste, everybody. Welcome to one more episode of our podcast, Rebooting the Brain. So many people have been enjoying the content of our podcast, our reels, and been giving us some rave reviews and comments. Thank you very much, each and every one of you. You are motivating me and my team to churn out more good quality content, and that's my promise. We'll continue to do this, and make it more and more enjoyable. Before I introduce the guest of the day today, let us start with the customary mantra. Om Asato Ma Sadgamaya Tamasoma Jyotirgamaya Mrityorma Amritam Gamaya. Om Shanti Shanti Shanti. This shloka has been a motivation for me right from my childhood. And as the shloka says, from darkness to light, from ignorance to enlightenment, and from death to immortality. You can use this philosophy anywhere in your life at any point of time and become a better human being. Try it, guys. You will not regret. So, today, before I go to the guest of the day, some housekeeping rules. Please don't forget to subscribe to our channel, YouTube channel, and the Instagram channel. Hit the like button for every video, share it as widely as possible, and don't forget to hit the like button and of course the bell icon, and make generous comments, because the comments helps us to get a better YouTube algorithm. So without any more ado, we'll go to the guest of the day, Dr. Venkata Krishna. Venkat, welcome to our show. So Venkat
Thank
and
you.
me are medical college buddies. 40 years we have known each other. 40 years from 1986. It's a long, long journey. We have gone in two different directions, geographically, but I think, spiritually and otherwise, we've been connected in more ways than one. So Venkat, he's a very different kind of cardiologist, and you will learn from that. So hold your horses. I'm going to tell you what's happening. Venkat, let's start the show. Welcome to our show, all the way from Minneapolis, USA.
Thank you, Sharan. It has been a great honor and pleasure to be here.
Welcome, Venkat. Venkat, we'll start with the burning problem everybody is asking. We've been reading stories about this guy in the gym, he collapsed and died. He was on the badminton court, he collapsed and died. Somebody was doing some fitness work, he collapsed and died. Running a marathon, collapsed and died. What's all these healthy, fit, younger people dying like this without even giving a second chance? What's going on? What is this called?
Yeah, this is a very great question. This is, I'll just date back a little bit. There was a famous person by name Dr. Meyerberg. He's still at University of Miami. I was giving a grand round several years ago. He sat in the front row. And that man is the one who described a lot on the concept what we call a sudden cardiac death.
This is called
So-
sudden cardiac death.
Sudden cardiac death. That's correct. So the interesting is the definitions may actually kind of give an insight into what we think as called as a sudden cardiac death. What it basically means is whenever there is an event happens, cardiac event happens, could be in the form of a chest pain or something, and whatever the trigger is, and if the death happens within an hour, it is considered a sudden cardiac death. Or otherwise, this is all witnessed. If it's an unwitnessed event, within 24 hours, if somebody dies, you see them healthy at 24 hours ago, and you see them dead within the 24 hours, is considered sudden cardiac death. So he dichotomized these patients into two categories. The first category is younger patients. Second category is older patients. They're less than 35, more than 35. Just to make it simple,
35 is the cutoff here.
35 is the cutoff. The idea of doing that is to see what is more common in that age group when they are younger. And by and large, if you take athletes into consideration, as you discussed rightfully,
That's what has disturbed people.
Yeah.
That those fit people, including some of the actors and all of that.
Absolutely. Now, one thing which is a big thing in the West that has happened for over years is a condition called hypertrophic cardiomyopathy, which is could be very underdiagnosed. And these are the kind of things which the first presentation could be sudden cardiac death, because
My goodness.
what happens is it's an unknown. They may not be very symptomatic with because of the cardiomyopathy that they have, and what triggers them is some sort of a profound exercise. So that could be one way of actually causing. This is typically about 1 in 600, somewhere around that. This is seen in the West more commonly. We know that for sure. There was so much underdiagnosed for so many years in India, but it is definitely there. Hypertrophic cardiomyopathy is much more than what we actually know. I know that a very well-known physician in Hyderabad, Dr. Narasimhan, has a big cohort of hypertrophic cardiomyopathy clinic. So that gives you an insight. This is something which is also here. It's just that we are recognizing more and more now.
So hypertrophic cardiomyopathy, we call it HOCM, correct?
Correct.
Yeah. So can you, since you brought it up, just can you give in layman's terms what is cardiomyopathy or hypertrophic, just so that they understand what it is and what are the common symptoms?
Normally, what happens? You think about normal heart. What is the normal heart? The normal heart is the ventricular walls are normal in size. In other words, less than a centimeter thick.
The muscle of
the muscle of the wall. When the muscle gets thicker, that is called hypertrophy.
like a bodybuilder
Yeah.
muscle.
Correct. If there is a reason for it to become thicker in the form of some blood pressure, high blood pressure, for instance, or hypertension, and the ventricle normally adapts to beat against the resistance by becoming thicker. But without having any good reason, if the heart muscle becomes thicker, then we call it as hypertrophic cardiomyopathy. It is usually driven by some genes. And there's more interesting treatment modalities are coming right now, but the more interesting aspect is this sets up a milieu, or in other words, an environment within the heart for arrhythmias. Apart from the fact that it can also cause other things like heart failure, but arrhythmias is the main thing we get worried about. So this is one of the conditions. The other ones in the pediatric age group also they can die suddenly is the congenital abnormalities in the form of abnormal developmental problems that could set up a source. The other one is a heart may look completely normal structurally, but they have what we call as a channel abnormality, ion channel abnormalities. It's a little bit more complex to understand.
Got it. So when you divided it into younger than 35, more than 35, and I was referring more to the younger people, though they may be around the 35, 40 years. I'll give you my own personal story of my own relative, uncle of mine. A very fit uncle of mine. He was 85 when he died. It's just a 2-month-old story. Bali Party me Deepavali Day 2025. He had a major surgery to the neck, Shabar had done, and about a year ago, came out very well and was fit and fine. No major comorbids, driving the car, cognitively very good. Previous day also has gone with his wife to his children's house and all of that for Diwali. That day morning, my auntie is cutting vegetables in the kitchen. They were talking. He's, at the back at the door of the kitchen. They're having a conversation. Her back is to him. And then after some time, she asked, do you want to have some noodles or something like that for breakfast because he likes that? And he didn't answer. So she repeated again. Then she turned back to see what's going on. She realized he was not there. So she said, where did he go? So no stress. He just walked out. She walked out and to the right hand side, just besides the door, he's kneeling down like this.
Collapsed.
He was gone.
Hmm.
He did not shout. He did not complain. He did not make any noise. And the classical, sudden cardiac death. And I was trying to convince my auntie and, things like that. And what is amazing was few days earlier to that, he was saying that if I go, you don't do this, papers are here, papers are there. And she's saying, why are you saying all that? You're healthier than me and things like that. But he maybe had a premonition with no logic. He was not like he was sick and, this is going to happen and things like that. So it is so strange that is happening about this. So as we go through, we'll understand that. But that takes me to the automatic next question is, when he collapsed like this, but he didn't die. Let's, for example, that we call as the fainting episode or syncope, for example. So can you tell us what fainting, dime a dozen, people are falling all the time, fainting in the hot sun, there's that, all of those things. Which is a faint, which is something worrying, which is simple, which is complicated? Can you educate our viewers on that?
Absolutely. I just want to thank my mentor, Dr. David Bendit, who is my mentor, who is actually the world renowned on syncope.
Really?
Oh,
I didn't know that. Okay.
I was trained under him.
Okay.
And the interesting aspect
which part of the US is he in?
University of Minnesota.
Oh, he's in Minnesota only.
Yeah,
oh, okay.
Right. And the interesting aspect of syncope is first of all, the definition of syncope. Syncope is basically the abrupt loss of consciousness due to, I'll explain to you all this, global cerebral hypoperfusion with complete recovery after the event has happened.
Correct.
So
blood supply to the brain goes off, then after some time comes completely back.
Completely back. So the interesting aspect is this syncope or the terminology is a momentary effect and it completely recovers. So it has to be some trigger which starts this process. The common notion when somebody comes, it is not just here. As far as the syncope world itself is concerned, in this country, many parts of the world, people do think, oh, who should be seen for syncope when they come to the emergency room?
Which doctor to be
Which
seen?
their doctors to be seen.
Got it.
So the false thinking is, the first thing is to say, oh, I need to send him, call the neurology, do expensive investigations like MRI, CT scans, all those things, and they find nothing.
Okay.
And then eventually they're struggling to figure out what exactly the reason for the problem. So
why is that? Why are they struggling?
That's because they cannot, the event has already happened. They don't know how to approach this problem. Okay. So I think what we ought to think about this way is the syncope, if you really look at common faint, in other words, it's called a common faint, 2/3 of these patients are because of what we call as neurocardiogenic reasons. So neurocardiogenic reasons means that whenever you are getting an IV access, somebody is putting a needle in the arm, people get lightheaded, or in a
they see blood.
Yeah, they see blood. Or it could be that when they are actually going to a bathroom, suddenly they become lightheaded and faint. or
I had one such episode.
yeah,
Micturition syncope.
micturition syncope. Then coughing spells, or even sometimes swallowing. I had a patient, very interesting. He came. He always said, every time I drink 7 Up, I get lightheaded and pass out. I said, what is 7 Up? Then you'll laugh at this one. I actually went to Holiday gas station, bought 7 Up, brought to the cath lab. I did a tilt table study on this patient. I said, okay, I'll give you 7 Up, and he passed out.
Whoa!
Then I figured out later it was carbonated beverage. What it was doing was it was causing profound esophageal spasm. So the
Crazy.
spasm triggered a neurocardiogenic response.
What?
So
amazing! What all can happen? Huh?
What all can happen? Is it right?
Alva,
So
crazy.
contrary to many people think, I gave him nitrates, which use a vasodilator. It's not a vasodilator in this case. It is a esophageal spasm which is relaxing, and then he got
But
better.
you gave it like a prophylactic
prophylactic course. So I mean, this is not the right treatment. I shouldn't say nitrate for everybody. This is something just to give you some sort of an anecdote. But most importantly, I think what we ought to think about in a syncope, which is the commonest one, we always address commonest as a first reason, is they need to lie down. The first thing, whenever somebody passes out, don't make them prop them up. Don't try to lift them up.
Don't put their head end up, because already the blood to the brain is less. If you prop them up, the brain will get damaged more.
Exactly. And they continue to be in the same state. Correct. So bring them down and then hydrate them. That's the key thing. When they wake up, hydrate them.
After they wake up. Don't put water before they wake up.
Before they wake up, yeah. And the spraying water on their face, all those things are not necessary. Okay. So then once they are in that situation, then you need to figure out how do we treat this issue. The key thing is to keep the volume up. The very commonest thing that happens in the US, this is a very common story, we hear it, is in the churches. People actually have too many people crowded, feels like little suffocating, and they stand up and they stand for some time. The next thing happens, they are fainting. This is a very common thing. Crowds, hot environment, stuffy places, they tend to also experience this similar kind.
Those place situations has more of a carbon dioxide buildup. Is that one of the triggers for this, or not necessary?
Not necessarily. I think it's mostly probably that sense of crowd. Then they're also standing for a long periods of time. They could be the first thing in the Sunday morning. There are many good reasons to have, and they're underhydrated. The other one, some people have this problem. They have a tight neck collar. For instance, ties, they wear them. So the carotid, sinus can get hypersensitive. This is more common in the older population. And they also can have the same issue.
There's a sinus here. When we say sinus, we can maybe explain that a little bit. What, in a layman's terms, what a carotid sinus is.
Absolutely. There is a neck artery which supplies to the brain, and there is at the bifurcation of one goes outside, one goes inside. There is a body, which is a bunch of nerve cells in that area. Those area that gets sensitive. So when you actually even tap on it in those kind of patients, they're very sensitive. Then you can actually slow their heart down or even drop their blood pressures. We call it carotid sinus hypersensitivity. So those kind of patients, you could have a fainting spell because of that reason.
So I didn't think about this.
Yeah,
very interesting.
So that is so there are many reasons that, as we discussed earlier, the situational syncopes, the micturition, then
micturition is when your bladder is full, you try to pass, and it happened to me once. Full bladder, and tabak, and I fell down very early.
Yeah, it actually, people do hurt themselves. The syncope may not be trivial because they may have a secondary effects because of that reason. Then the more malignant kinds are the ones we talk about, the cardiac.
The dangerous ones.
Dangerous ones are the cardiac syncopes. That could be heart rhythm related.
What is that?
So heart is, as you know, it starts in the top right chamber of the heart, which is called a sinus node. Sinus node is the natural pacemaker. We're all born with a natural pacemaker. It has got its own rate. It has got a setup. Its rate somewhere around 60 to 80.
Or pre-programmed.
Pre-programmed. Whenever you're sleeping, it goes down. When you're exercise, it goes up. So it has got a natural tendency to go up and down. So it has got electrical connections coming down to the center of the heart, which is called the AV node, atrioventricular node. That's another subsidiary pacemaker. And then the top chambers are also interconnected through the muscle fibers.
So SA node is also a pacemaker, AV node is also a pacemaker.
Pacemaker.
Yeah.
But
And they
it is
work in tandem.
sometimes they say SA node is not as effective. Sometimes AV node can take over some function, but not necessarily is as powerful as the SA node does. Then the conduction gets through the center of the heart to the both ventricles through a complex arborization or branching of electrical specialized muscle fibers, which is called the Purkinje network. Okay, so the Purkinje, I was actually happened to be in Prague. There is a big statue of Purkinje.
Oh, that?
Yeah, he's
Oh,
a famous
I didn't know he was a
physiologist.
Czech.
Yeah, he was a Czech
Oh, I
in
didn't know that.
1800s.
I see.
Yeah, famous. They were very amazed by the fact that in Prague they respected a physiologist, and he has got a big statue in a park. That is very unusual.
Amazing, very.
Yeah.
See, when I introduce you as he's a cardiologist, what is your view of cardiology? The cardiology means heart block, stent, bypass surgery. Correct? No, all that is to do with the blood vessel or blood supply, or blood pipes that goes into the heart. This is what commonly people know what is going on. The not so common thing, what Venkat is an expert in, is called the heart's electrical circuit. Like an electrician, like I also deal with electrical circuits of the brain. He also deals with electrical circuits of the heart. So he is now describing this whole system of how an electrical circuit has been designed by God to work and what happens if it doesn't work properly. And this whole episode is about misbehaving electrical circuits of the heart. Have I summarized it correctly?
Absolutely.
Yeah. So now you can continue with your circuit business.
Yeah, absolutely. No, I call myself an electrician when I introduce to the patient, because I tell them, look, interventionalists are the people who put in the stents are the plumbers, and we are the electricians. So what is it? Both are required.
Correct.
And they are mutually important. We cannot ignore either one. And what actually precipitates as a sudden cardiac death, what we think about a very serious arrhythmias, they're all coming from the electrical side of the brain. So in the electric side
that's
of the
why
heart.
I brought that up,
Yeah.
because they don't give you a second chance many
Correct.
times.
Yeah, absolutely. So continuing on, one of the aspects of syncope you mentioned was slow arrhythmias. One reason the patient develop a conduction system blocks at various levels.
Maybe the current is not passing correctly.
Yeah. Either it is not coming out from the sinus node, becomes very slow, or the center of the heart may actually get disconnected from top and bottom chamber. Then you have a heart block. Heart block is electrical block. It has nothing to do with coronary artery blockage.
Because the block they understand is the pipe block.
Yeah.
They don't understand the conduction block.
Exactly.
That is the two blocks. One is the plumber block, other one is electrician block.
Electrician block. And these electrician blocks are the reason why people receive pacemakers. Okay, you have a lead which is placed in the one in the top chamber, one in the bottom chamber. They actually talk to each other. The generator has a brain behind it. We implant beneath the skin, and the other ones go through the veins into the heart, and that actually delivers impulses. Nowadays, the leads are also replaced by leadless ones.
Oh, that?
Yeah, leadless.
Oh, I didn't know that.
Yeah, we actually place a leadless. Leadless.
How does that work?
We are going through the the groin up into the heart, and there is a little tiny fangs. There depends on the different company. One of them is active fixation with a screw, tiny screw into the heart muscle. Another one is a little passive.
Where do you place it? In the interventricular septum?
In the ventricle apical location is one thing, under the right atrial appendage. So they talk to each other.
You have two wireless.
Separately.
Oh, so two
wireless.
Okay.
They can talk to each other separately. And
interesting. I didn't know this.
Yeah, there is a new thing even coming, which is obviously very interesting aspect of it. It's much more advanced concept. We've been really doing a lot more in the conduction system pacing, which means that we pace in such a way it looks like a natural rhythm. So we directly capture that electrical fibers I was mentioning earlier. So in that way, it takes the same path of the electrical fibers.
So you use it to augment
the conduction through that.
Conduction.
So
use the natural stuff.
So in a sense, the heart, when you look at the ECG, it looks similar to their native rhythm when they are in health situation. So it looks as good as that. So
you are saying that before sometimes the pacemaker rhythm does not look like a normal.
No, it cannot look like that. If you're just pacing in the ventricle, it looks differently. Yeah, that's because you are activating from a different location.
So before we go deeper into understanding, so he is talking about rhythm problems in the heart. And then when the rhythm doesn't go, properly, all of you have heard this Kannada song, Nanna Yede Dava Dava Ennutide. And the Dava Dava business is because of the heart rhythm. Other Hindi, English, everybody has similar songs. You have heard, you'll be hearing that as I'm talking. Now, before we go into what he does with abnormal rhythm, we call it arrhythmiologist. I want you, Venkat, to tell our audience what is a normal cardiac rhythm. Let us start from the fundamentals.
Yeah.
What is the normal ECG and what is the normal rhythm?
Absolutely.
Yeah.
So we talk about normal rhythm is normal sinus rhythm. As I mentioned to you, the top right chamber, this natural pacemaker, when it starts producing an impulse, it goes through the center of the heart into the ventricles or the bottom chambers. As the electricity passes from top to bottom, the heart muscle serially contracts. It just follows the electrical path and contracts. So there is a little delay from electrical
Amazing,
activity
no?
to muscle contraction.
Amazing how God has designed
Yeah.
this. Allah,
Yeah.
amazing.
It's just like, you tap on somebody, you have a response. Is that right? So that tapping is happening inside constantly, and it is responding by
So
contracting.
no work-life balance, no rest,
There is
no
no rest.
weekend off,
Yeah.
no post-duty off. Yeah, Father.
No, there is
such
nothing like
offs.
that.
Nothing like
I mean, we cannot afford to
that. You
have
can't afford to
have a
that.
work-life balance there by
To
stopping
correct.
working. Yeah.
Not even for 5
That is
minutes.
it takes rest in between in the what we call as a relaxation.
Oh,
The heart
that?
muscle, yeah.
Oh, smart
The
fellow.
diastole has got some relaxation. Although we more and more we think about it, it's not totally a relaxation. There is energy kinetics still working in that situation. But there is more and more also concept because of the fact that the electrical, when you do a pace in a situation like this, we call as dysynchrony. When you activate in one side artificially, we are trying to mimic the natural pathways by synchronizing the heart. This is just a pacing concept, what I was talking about.
But coming back to normal heart rhythm. Yeah.
So then the ECG, which represents the normal rhythm from top to bottom chamber, you have what we describe as PQRST. Einthoven was the one initially did the first ECG, and he described this concept. And there are many interesting waves we described by different people, the name terminologies. But I think we stick to the normal ones. So the P wave is actually basically comes from the top chamber. There is a little period of timing we call as PR interval. That is a time which takes from the top chamber to go to the center of the heart, which is the AV node. Then afterwards, the bottom chamber starts the QRS complex. The QRS complex is all happening in the ventricular activity that results in ventricular contraction right after that. And if you simultaneously place a catheter in the heart and timing with an ECG, you can actually see the activity when the contraction happens after when the electrical activity starts at a particular location in the heart. So you see
can map
that
it actually.
you can map it. Yeah, there is a very good sync that you can actually see it.
Got it.
So that's basically the normal pathway.
PQRS. And then T?
T is the repolarization. Okay, repolarization is it's a recovery of whatever it's happened. So it starts from the epicardium all the way down to endocardium. What it means is all the activity starts electrical is inside the heart. All the fibers that I'm talking about is inside surface of the heart. Then it goes through the muscle wall to the outside of the heart. Then it returns back the same way. Not the actually wave front, it's a recovery that happens in the same way. So in that way, there is this all the muscle which uses
PQRST, 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 ad nauseum.
Yeah,
it keeps going.
Keeps going.
Yeah, keeps going.
So when the heart becomes too slow, we call it sinus bradycardia. When the heart becomes too fast, we call it sinus tachycardia. Slow is less than 60 by definition. I mean, it
beats per minute.
Beats per minute. But remember, athletes, the elite athletes can have heart rate of 40. That's just totally fine.
In fact, our famous tennis player Bjorn Borg had a resting pulse rate of 40 or 44 or something.
Yeah. It is interesting.
That's why he was called iceberg.
Yeah, my heart rate is always in 50s, sometimes even in 40s.
Really?
I'm not super athlete, but I'm
inborn. You've got inborn protection.
So it's a slow enough, And the tachycardia is more than 100 beats per minute.
Got
This happens most often when you're exercising,
Correct.
doing some
Or
activity.
anxiety or anything.
Anxiety or anything can provoke like that, can do that. When it comes to fast heart, we talked about the slow heart rhythms. And I mean, one thing I want to also mention is the slow heart rhythm not just happens because of the top chamber, which is the natural pacemaker, but also we call as electrical blocks, which is the block between the top and the bottom chamber. There are various degrees of heart block that you see. There are certain types of heart blocks which actually are the ones which becomes more
So heart
malignant,
block means if the current is not passing properly
passing
between the two
properly
fellows.
between the two chambers, top and bottom chambers of the heart. That's when you need a support. Sometimes you may not have an
This is
escape.
the electrical block he was talking about, not the plumbing block.
Yeah.
Huh.
Sometimes if you are lucky enough, some patients I've seen them, they come back with just fatigue and high blood pressure. You may think it's all because of high blood pressure, but actually electrical block between top and bottom chamber. And because there is an escape rhythm, we call it an escape rhythm.
Mm-hmm.
That
What is
means
that?
it starts in the center of the heart or in the down in the ventricle itself. That takes over the function.
But these two fellows are not working properly.
Yeah,
I didn't know this.
Yeah. So that itself can keep going without having patient fainting.
God has given a backup mechanism.
Backup
also.
mechanism.
Oh.
Yeah, but it may not be effective in everybody. If some people who are lucky who present like that. So
Until they are completely asymptomatic, they have some vague symptoms, and
vague
when you
symptoms,
actually
fatigue,
investigate,
or even hypertension, something like that, or very slow heart rate. And often, our patients say, I was checking my blood pressure. My blood pressure apparatus was showing my heart rate is too slow. So that's when I think we
that's
need
the
to
first red light should
red
come
light
on.
should pop up. Then in that situation, you place a pacemaker depending upon some technique things we actually evaluate in the form of function.
Since you brought this phrase heart block, which is the electrical heart block, so there are three levels of heart block, no? Heart block 1, 2, 3 or something. Can
Correct.
you explain to them a little bit and
Sure.
what are these three types of heart blocks?
Yeah. As earlier mentioned to you, we call as a PR interval in the ECG. We call as a first degree heart block. If you talk to Dr. Mark Josephson, who was like the father of electrophysiology, who did a lot of work from Harvard. He was at University of Pennsylvania originally. He never used to call that as a heart block. It's just because prolongation of the time. Prolonged
PR
AV
prolongation.
conduction. Prolonged AV conduction. So top and bottom chamber, there's a prolonged timing. Okay. So that is usually, most of the times it's benign. Okay. Occasionally it can be a problem when it's extremely long. Okay.
Benign means safe.
Safe. Okay. As far as the other ones, there is a second degree heart block. Within that, there are two different types, because type 1 and type 2. A lot of time, type 1 can happen in normal individuals when they have a too much of vagal response. For example, you're bearing down or in the sleep, vagus is very active, vagus nerve, one of the cranial nerves, then the heart rate may become very slow. In that situation, it's usually benign, not of a big consequence, unless they are symptomatic. If they become very symptomatic with that reason, then in that case, they may still need a pacemaker. And the type 2 second degree heart block is a little bit different, where you look at the ECG and there is a clear drop beat between top and bottom chamber without having that PR prolongation or the timing interval. In that situation, it can progress into a complete heart block, which is the third degree heart block.
Okay.
Okay.
So what is third degree heart block?
Third degree, there is a top and bottom chambers are not talking to each other.
They're on their own.
They are on their own. In that situation, they need a pacemaker for sure.
Divorce case over there.
Divorce. It divorces from top and bottom chamber.
What happened? How does the patient present?
Yeah, they can present, say, as I mentioned earlier, they can present with just fatigue, or incidentally picked up with slow heart rates, or they can present with a very high blood pressure, because it's very interesting how the body tends to compensate for whatever is happening.
I didn't know this blood pressure component at all of heart blocks. I always thought they'll have a syncope, something else.
And that can also happen.
Okay.
Say syncope, depending upon how much they actually drop and how much they escape. But that can also happen.
So you see this, constantly you're telling this high blood pressure, that started worrying me. I'll tell you why. Because see, as a neurosurgeon looking at strokes, every stroke fellow has got high blood pressure. But everybody, we're not chasing for a electrical problem of the heart, honestly speaking.
Mm-hmm.
So are you saying that should become a part of the standard of care for me to actually look at every patient? What are you trying to say with this?
Well,
or what would you recommend?
Any stroke, automatically we look at heart.
No, but
we
we
want to
don't
make
look
sure.
at, we just do a
Yeah.
normal ECG. That's
Correct.
it.
Yeah.
We don't go beyond that
Beyond
to
that,
look.
yeah.
We don't look at
In
beyond
the
that.
absence of a serious rhythm issue, probably it's not an issue.
Okay.
If you have a serious rhythm issue, you need to look at it as a, you cannot ignore it, in other
Yeah.
words. Yeah.
Once we see
In that
something, then we
yeah,
chase it.
chase it.
Huh.
Then maybe I think the hypertension may be somewhat related, may not be related, or it could also be compensatory, as you know. That can also happen. So that's what I think is we need to keep in mind. I mean, I think nobody is doing wrong. It's just a question of just when it comes to the physicians, exposure. The patients need to be exposed to the physicians in a situation where it needs to be addressed. We cannot ignore that. That's probably the message I would want to give. When it comes to the fast heart rhythms, that's probably most important. I think we have to be very, very careful about this. The fast heart rhythms is slowly picking up in this country.
Picking up is diagnosis.
Diagnosis. I'll tell you, there are benign fast heart rhythm that can happen. We call a supraventricular tachycardia. That means it comes from top chambers. It drives the bottom chambers also fast. Usually, most of them are benign, but they get symptomatic. They may faint. It's possible. It's not like it's killing. Okay, there are exclusively very rare ones which actually fastly conducts to a point, actually go to a bad rhythm. But they're besides that.
So give me some example, like what do you mean by how will the patient feel, or something like how do they reach you?
Yeah.
Or how do they? Is there any way that they will reach us
Absolutely. And they come. I mean, most of the patients present with palpitations. That means heart is beating fast.
at all? I can feel my heart beating.
Yeah, that's correct. And some patients may feel lightheaded. Some patients may feel short of breath. Some patients may even faint. I have had patients with this so-called as benign supraventricular arrhythmia have fainted. So that can also happen. It's a complex mechanism that can actually drive that way. So that is one aspect of it. The other one is actually the rhythms which originate from the ventricle, which is the bottom chamber of the heart. That could be dangerous. Okay, that could be dangerous in the form of causing. It could even lead to sudden cardiac death. So that is something we have to keep in mind.
Before you go deeper into that, so what Venkat has said so far is slow heart rate related rhythm problems, fast heart rate related rhythm problems, correct? The slow heart rate rhythm problems, we call it in medicine as bradyarrhythmias, and this is called tachyarrhythmias, correct? Now, before you go deeper into that, I remember when I was training in MBBS, to remember all this complicated stuff as a MBBS, still like the Murray doctor, regular heartbeat, regularly irregular, irregularly regular, and irregularly irregular. And we used to actually make a joke, hey, in irregular, in classic barala, we used to say all of those things. So it used to be fun for us as students, 18 years, 20-year-old guys. We had no idea about what the heartbeat was all about, except an ECG graph to pass the exam. As we obviously grew better. So can you tell us how these four phrases fits into what is going on and what is the concern of each of them?
Absolutely. It can get complicated to really explain, but I will try to be simple as
Sure,
possible.
sure.
So the commonest thing, rhythm, what we talk about, atrial fibrillation, which is becoming
AF ಅಂತ ಹೇಳ್ತೀವಿ.
AF ಅಂತ ಹೇಳ್ತೀವಲ್ಲ, that's becoming, in fact, I would say like a epidemic.
Really?
Okay. It is
Epidemic?
not. Yeah.
Why?
It's actually throughout the world. West is actually becoming, as there are many reasons to it.
Epidemic is a dangerous phrase.
It is dangerous phrase, but I would say it because of the fact that the incidence is becoming, quite high. Western population is high, not just the West, even in India, it's becoming very high.
Why?
So,
any particular reason?
The commonest association we see is aging. Okay, commonest here. Then the second,
that means we are living longer.
We're living longer, and we are seeing it. Number two is high blood pressure can precipitate that. Then any reason to develop what we call as heart failure. The heart failure is people have misunderstood for so many years. They equate heart failure as a death. It's not really failure. Heart means it's under functioning heart. In fact, the function of the heart is reduced. Normally, every time it squeezes the heart muscle squeezes, it squeezes about 55% of the blood volume or higher. But if it is not squeezing, because it doesn't empty completely, so there's some blood left behind. If it's doing less than that, so then the heart function is weak. So that could
55%
55%. Yeah, that's a normal. Yeah. So if it's low, it can create a sequel of problems in the pooling of the blood. then get short of breath because lungs also get then swelling of the feet.
Forward problems, backward problems.
Backwards, yeah, exactly. So that's when we talk about what you call as a heart failure.
And what are the classical symptoms of heart failure, since you brought up that phrase of heart failure?
So the classical symptom is shortness of breath, weight gain because of fluid. Because they swell up. And then then the rhythm related issues can also result from this problem as well. So all these things can happen. Now the heart failure, not only functioning, a lower function of the heart itself can precipitate the heart failure, even the normal functioning of the heart also can precipitate heart failure. How it does is become stiff. Instead of contractile problem, now a relaxation problem. That's another thing which is becoming extremely common in the Western society.
Why?
When we, once again related to aging. Aging is one of the reasons. It's like aged heart. We age as the heart becomes older and older, the heart becomes more stiffer. So there is another new infiltrative condition called amyloidosis, which is protein deposition in the heart. It's becoming extremely common. I think we are recognizing more probably.
You must be recognizing more. I was just going to say that because we see it very common in the brain also.
The brain. And probably it's the same syndrome.
The funda must be the same,
it's just that I think we are seeing more and more.
A lot of these etiologies are common between the heart and the brain.
Exactly. I think the body is very interesting how it actually tends to adapt, sometimes maladaptation, functioning, which leads to other, Going back to the atrial fibrillation. So this atrial fibrillation, because of all the reasons that we think about, the top chamber, instead of having one pulse.
So atrium is the top chamber of the heart and ventricle is the bottom chamber of the heart.
It needs to contract top chamber and the bottom does the same way. The top chamber now is masqueraded because the natural pacemaker is not functioning. The atrial fibrillation, most of the triggers, we call as triggers, come from the veins, which are the veins which receives the blood from the lungs after the lungs oxygenate them and drops into the top left chamber of the heart. So that area suddenly starts firing electrical discharges, and that can be as fast as 300 to 500 beats per minute.
What?
So it's extremely fast. So
300 to 500.
Correct. When you place a catheter there, it may be that fast. So what does it mean to you?
But you can't measure it in the pulse rate.
No, you don't because it's chaotic.
Correct.
So it becomes what is called fibrillating. In other words. So it doesn't.
Fibrillating is only like this.
Exactly.
It's not pumping at all.
It's not pumping. There's no mechanical function. So that's when the atrial fibrillation becomes a problem, because the blood pools, clots can happen, the clots can go up somewhere in the brain, can cause stroke.
Correct.
Those are the
That's
things.
when we are seeing. So I'm actually thinking, as you said, that the AF has gone up because we are seeing more and more AF related strokes. I'm just scanning my last many months of stroke data in my brain, and I'm seeing that. So I'm saying, I should start paying attention to this more than probably.
Absolutely. When we were training, I remember the number one cause of stroke was actually, we call as the internal capsule area. All these are all related to the vascular, somewhere in the carotid, somewhere deeper down into these areas. But it's actually much more common with embolic now. Embolic is becoming more common.
Because then they come with TIAs, and they go away and they had a mild stroke, the transient ischemic attack is what we call, and sometimes it's not neglected, and then, like your own uncle, we've been debating what is happening, the classical situation, chasing it down. So when you're talking about sorry to butt in about atrial fibrillation. So you said 300 to 500 because you put a catheter inside, you're measuring that.
That's how we know it, yeah.
So otherwise, clinically, how do you pick that up? In a sense.
So that's a very good question. So one of the easiest ways to know is ECG. Okay. You do an ECG and you see one thing happens. You don't pick up those P waves I mentioned to you earlier, which is the activity of the top chamber. Instead, you see the undulations. That's when then what we see is the bottom chamber is very chaotic, irregular, and it's the irregular heart. That's what we were talking about earlier. So that can happen because of the some beats come early, some beats come late. There is no regularity to that. So that's when we call as irregular heart. So that's
you can pick up on a normal ECG itself.
Normal ECG itself. Yeah. So, but for us as electrophysiologists, we dive deep into the chambers of the heart because we do some interventions for those kind of procedures, and hence, we see them, what is happening within the heart chambers.
So now I know as a neurosurgeon is if I feel that there's something going on, I call the cardiologist, he comes and sees, then he recommends a Holter test.
Mhm.
So can you tell our viewers what is this Holter? How is it different from just an ECG and what it does?
Yeah, absolutely. So ECG, as you know, is a snapshot. When somebody comes to you, you do an ECG, you get 30 seconds, whatever it is. That's all we know. So we don't know what happens from between now and the next visit. So sometimes it may be better to record this ECG in a continuous basis. That's what they call as a Holter. So the Holter records commonly 24 hours, 48 hours. You can even do nowadays what we call as patch monitors. We actually place a patch and records for 2 weeks. So we can actually do that. And needless to say, the other things which is called implantable loop recorder, which goes beneath the skin. It's like a little injection. You can actually inject beneath the skin. And then that can sit for about 2 to 3 years. So you
3 years?
yes, the battery is capable
No,
of
no,
doing
but
that.
why would you want to record? I mean, it
So
picks up.
not just the atrial fibrillation part. So sometimes you can use for atrial fibrillation because you intervene or do some activity, I mean treatment, then you can see the progress, what's happening.
You want to see progress.
Yeah, that's
Got
one
it.
method.
It's just okay.
The
Got
other
it, got it.
reason is we talked about fainting spells.
Mm.
Some fainting spells can happen very unpredictable, occasionally. Then you cannot pick up with a Holter, which is very fixed time. So, it didn't happen. It didn't happen for 6 months. One day it happened. If you are lucky to pick up that one, then you know
No,
the
but
problem.
you're psyching me up because I mean it's like I'll become like a cyborg walking around with all these things going around. For every small episode we have, we get psyched up. I'm just guys. At the end of the day, what we're trying to say is don't listen to both of us and then go and ask for these tests. Go to your closest cardiologist or whoever doctor who understands this science and let them make a decision whether you really need it or not. Electrophysiologist in cardiac surgery is one step different from just a standard cardiologist. They'll have like how I'm a functional neurosurgeon. He's an arrhythmiologist or electrophysiologist, so that's what it is. Got it. So now that you have done X number of tests, then you picked up a cardiac rhythm problem. So now you have made a diagnosis. So let me just to summarize for my guess. Number one, you have studied the cardiac rhythm. You have decided it is not normal. Okay. Then you started saying what is not normal. Is it a slow not normal or a fast not normal? Correct? Once you have done a slow, fast, non-normal, is it a physiological slow or within the normal ranges of fast and slow, or is it something to worry about? And correct, that's the next level you are making a decision. Once you make that next decision, you are now deciding to say, is it coming from the upper chamber? Is it coming from the lower chamber? What's the connection between the two? Where is the connection problem you're seeing? And then sometimes to study it more, you do a Holter test or something like that to get more data out of it, or a loop record or whatever it is. So this much, have I understood it right in
You
so
are
far?
absolutely right.
Perfect. Now with all these things you have decided, there's something going on here and it is abnormal and he needs more testing and more treatment. Others he can die if he's not treated. Correct? That's my
It can
understanding.
happen. It depends on the condition.
Correct. Now you tell us, take it further from here and say what next.
Absolutely. So the one thing I wanted to stress upon is the bottom chamber rhythms that we call ventricular arrhythmias. Those are as I mentioned earlier, can be deadly ones. If you do pick up any of these monitors, then you need to find out why they're having this problem. So it could be in the form of we need to possibly consider doing an imaging of the heart, see how the heart function is.
What
Could
kind of
be-
imaging do you do?
We can start with an echocardiogram. Echocardiogram is ultrasound of the heart. So that tells us how the heart is squeezing, how the heart valves are functioning, all those things. And if
You
there
can
is
see it actually.
you can see it. And you can actually measure the severity of valve issues and things like that if there is a valve problem, and also the function. And then once we determine that, let's say if we cannot find a reason, then depending upon what the issue is, bottom chamber particularly, not much for the top chamber for doing an angiogram. I think sometimes people do inadvertently doing angiograms that are needed for atrial fibrillation, but the bottom chambers particularly, if they have a bad arrhythmias, then you have to possibly consider looking at some form of evaluation, making sure we're not dealing with serious coronary artery disease.
Which itself can be causing secondary.
Correct.
A plumbing problem causing a secondary electrical problem.
Secondary electrical problem. So, you could be doing as simple as a CT scan, the CT angiogram. That may actually give us some idea, insight, whether to do an more invasive angiogram. to determine a little bit more. Then that is another method to do it. Sometimes we cannot find a solution from coronary artery disease. Then in that situation, we may have to find out if it is indeed some structural abnormality. Hypertrophic cardiomyopathy, as we discussed earlier, is one of them. Then there's some other infiltrative cardiomyopathy. Sometimes, otherwise, deposition of protein and other things that can happen in the ventricle. And the other ones are the heart actually has some genetic issues, that gene related issues that can actually produce a very sick, dilated, or the enlarged heart. That can happen, primary muscle problem. Then do an MRI of the heart, then to determine what is happening. MRI of the heart, it's very well done. And once and occasionally we have to do a biopsy of the heart muscle.
How does MRI pick up the heart will be beating? You will not have movement artifacts. And
it is very well actually timed. It is very well timed.
So there's a proper sequence for that, huh?
Sequence, and you can actually pick up very nicely. Yeah, I'm sure they're doing it. It's actually you can actually determine very precisely. In fact, just to give you a little bit of idea also, because I have a little bit of I want to step myself outside the boundaries, so in the form of innovation. So I work also, consult for another company. In this company, what we do is we do a lot of interventions MRI based. So there is a live MRI. We can actually visualize live MRI with the catheters in place.
Really?
Yeah.
You mean you have a MRI? It's like an intra-op MRI like that. You have
Correct.
something.
Correct. You place the catheter.
So the MRI and cath labs are next to each other.
Within the MRI lab itself, we do the procedure within the MRI
crazy.
lab. Yes.
Really?
Yeah. So that is actually.
I've not heard of this.
Yeah, this is in a very early stage, I would say.
I see.
I think it's particularly the pediatric cardiology where there are a lot of complex congenital heart problems, post surgeries, so many changes they have done. You can actually see the live structure very, very well.
And then what do you do?
Then
why do you need a live real-time imaging?
For example, you have a structural problem. The ventricle has a scar. The arrhythmia is occurring from that location. You can precisely see where to target.
So when you're doing only the cath, you see only the electrical stuff. You don't see the physical
thing.
So you're trying to do the physical matching to the electrophysiological mapping.
Correct.
That's the goal of these two things.
That's the goal of two things. Now we do currently use a different method. We use what is called electroanatomic mapping. We use it's a complex algorithm, multiple catheters. It's a very complex subject to explain. But anyway, we can still get a different inference. But the MRI is becoming more and more, and also limits the radiation. That's a big thing. We don't have radiation from the MRI. That seems to be another.
That's actually, it sounds game changing to me.
It is very interesting. It takes time to penetrate anything new system, whatever comes in, but it will be something interesting in the future for sure.
Because see, anyway, MRI has become a standard of care everywhere. So I think to sort of merge it inside, and people will start looking at it differently.
Yes.
Very interesting. Is it the standard MRI that you're using, or is there a special MRI for these kind of things?
The MRI can be standard, but it also comes with the mapping. It converts into different color-coded maps. So you can actually use the color-coded maps with the MRI. So then, you transform the rhythm into a color. So each early is one color, late is another color. So you can actually use a color-coded map. You can actually see how the rhythm is
you should
moving.
be trained very well on reading the maps in real time, because you'll be keep changing quickly. So you should be able to, your brain has to be registering that patterns in your brain to pick up a normal pattern from an abnormal pattern quickly.
Yeah.
So to be able to take action. Interesting.
And going one step back again, as I was telling you about, once you determine the heart function, the scar is issue or some reason, then next comes is, so what is the risk of these patients with heart failure or the heart function being down? In that situation, we need to, one thing which is...
What do you mean by risk?
Risk. So the risk is basically when the heart function goes less than 35%.
The ejection fraction.
Ejection fraction. Then you do everything possible to bring it back in the form of good medical therapy. That's probably one of the most important thing we need to do, which is the American Heart Association, American College of Cardiology, European Society. Everybody has got, and the Heart Rhythm Society have guidelines. So these guidelines, according to that, you do everything possible with medications. There are standard of medical therapy that are available. And once you actually do all those things, if still the heart function doesn't improve, if the heart function is less than 35%, the risk of dying suddenly is very high.
So can you, since you brought up a new phrase of heart function and ejection fraction, can you spend 2-3 minutes on explain what is this ejection fraction and
Yeah.
what does it imply to them, so that they are sort of aware of it, because EF is shown very commonly in every echocardiogram report.
Correct. So the ejection fraction, or the what we talked about, is a very good question that you asked. When we talk about the heart squeezing function, every time the heart actually squeezes, it squeezes only 55% of the blood volume, as I mentioned earlier.
It means 100 ml comes in, only 55 goes out.
55 goes
45
out.
remains back in the heart.
Correct. It remains in the heart. So, in other words, heart doesn't become completely empty. It doesn't just shut off completely. So it has got that amount of blood that is left.
I know. Is there a particular physiological reason for that, or?
Good question. I'm not. I don't know. I can answer that question very well easily. There should
Sorry,
be a
just came to my
physiological
mind.
reason. Yeah. I think in part, I think the muscle, actually, the architecture and the skeleton of the heart remains the same. It is not geared towards completely empty.
It doesn't obliterate the
Yeah.
space completely.
Interestingly, since you asked that question, if for some reason somebody is dehydrated, for instance, we see that when you're doing a procedure, the heart becomes super contractile. The heart ejection fraction can be 80%.
Oh.
So in that situation, it empties completely.
Because the need is there. The
Yeah.
periphery is giving a need.
And because of that reason, you can see the outputs actually goes down. Physiologically, it goes down. So this can happen with hypertrophic cardiomyopathy. There is hardly any space. It becomes so thick, there is no space. Then the heart struggles to keep up with the volume. You need that volume to have a good output, in other words. So there is always some natural way of actually doing it. So when the heart function goes down, means ejection fraction goes down. What is it? The 35 came on based on the trials. Okay. Nowadays, I think we are more and more understanding, even between 35 and 50 or 55, there are some certain situations you may still having problems. You can have problems, but you need to be, that is still kind of coming up slowly. And as I was telling you, even a normal function, patients can present with
So
symptoms
what
of
is
heart failure.
so-called normal EF?
So the normal EF is 55 and above.
55 and above.
Yeah.
Got it.
Mhm.
And between 35 and 55, does it fit into some other?
Yeah,
You are saying-
there are many terminologies people have
Okay,
used.
got it.
The mid-range, like a reduced ejection fraction, or sometimes we call it as a heart failure with preserved ejection fraction. That means when the heart function is looking normal, but they have symptoms of heart failure. In other words, we call it HFpEF. Okay, HFrEF is the terminology used for
HIF,
reduced
RF,
ejection. HFpEF. Yeah.
Okay, HFPF.
Yeah.
So now, since you brought up such an important topic of heart failure, heart function, ejection fraction, now you have this constant health checkups that keeps happening, master health checkup, or, preventive health checkups, especially because India is such a high risk of coronary issues or cardiac issues in this country. So there we are recommending, sometimes I also do once in 2 years, TMT and ECG and all of those things. So do you recommend the echo be a part of every such test as a part of it, or what would you recommend as a cardiologist who's also an arrhythmiologist?
Yeah, it's a good question. I don't know. It answers always the question, meaning, you may be chasing something which may or may not exist if you really routinely want to do the echocardiogram. But if there is a suspicion, clinical suspicion, it's just like, sometimes you order a test. What is the implication of ordering a test? You need to know why you're ordering
So
a test.
basically, you are saying so that the audience, because they should not go and say, do echo.
Correct.
They should not be echo Q outside because there's a
Because of
Venkata
the
Krishna
reason.
show, and then we'll be in trouble. What is going on?
Yeah.
So guys, what he's trying to say is ECG, TMT you can do, but you don't have to routinely do echo every time unless your cardiologist feels so that there's an indication for that, and leave it to the experts to make that choice. Perfect. I think you've hit that. So before we go further into this, you spoke about the no disruption, no challenge, no learning, and all of those things, and that was something that you had a principle of your life, and actually even before you do that, I think we need a song. I think we need a song just to, it's gone so much. Everybody's heart is going da 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 da. Is it? I'm quite sure that many of you are measuring gear, keeping gear, seeing what's happening. Now he'll calm you down with a good song. Come on, Venkat.
Since I think it's something to do with the knowledge and Goddess Saraswati, it'll be nice to sing something relevant to that. And this song was also sang by Dr. Rajkumar. Very, very, there is no way that I can replicate any of them, either S.P. Balasubramaniam or Rajkumar, but the tribute goes to both of them. And I just want to say the one which actually, a very short version of it.
Sure.
Okay.
Yeah, just a few lines.
Manikyaveenam mupalalayantim madalasam manjula vagmelasaha Mahendra Neelajyuti Komalangim Matanga Kanyam Manasa Smarami Chaturbuje Chandrakalavatams Kuchonnate Kunkumaragashone Pundrekshu Pashankusha Pushpabanahaste Namaste 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 Jagadeka Mata
Brilliant, brilliant. I
Thank you.
think you gave a perfect rendition at a perfect time. My rhythm has come back nicely back to normal. Now I'm calm now. I can go on with this rhythm business that Venkat is so nicely elucidating for us. Venkat, now we have to go. See, the disruption and the no learning, no chaos, no challenge. Where does that come from in your life?
Yeah, it came in several stages of my life. Okay. The thing is, economics play a role in anybody's role, in different ways. And, my father was Tahsildar. But he retired in 1976. So at that time, it's interesting.
Oh,
He was
1976?
76.
10 years before
Extreme.
you actually got into medicine.
That's right.
Oh,
That's right.
so you're the baby in the house.
Baby in the house. I was the baby of the house.
Oh, I didn't know this.
And it's so ironic that his pension was so little. You cannot even imagine what can you even manage. Okay, but that economics has one of the impediment. You could think that could cause the problem, but by good fortune of both my parents, especially my mother, because she went through in her life what she really wanted to do. All those in those days in late 1940s, she was a Mount Carmel College student. She really wanted to do medicine.
Pre-independence.
Pre-independence. Then
Oh, she wanted to be a
right after
doctor.
independence, she wanted to be a doctor,
Uh-huh.
and she got into medical school at that time, and then, but due to many social circumstances during that time, she ended up not able to do the medical school. Hence, I had to. She had in her dream one of her children should get into the medical school, and that drive was constantly there. But the question is, how do you culminate the drive and this situation in the house?
Dream on the drive.
Yeah, but my father, despite all the things, he worked very hard, no question, to really bring me to a level where I could potentially compete with the situation where I could get in. And needless to say, that all the scholarships really helped a lot along. Many people helped and contributed. And that was one of the things which actually brought me to a level where I could potentially go further in my life. So that was the thing.
So you had a lot of scholarships and financial support when
That's right. That's right. A lot of scholarships came through. Many trusts, National Merit Scholarship, many things like that. Then subsequently.
So that didn't stop you. So the money didn't stop you from achieving what you wanted, apart from the psychological support, but you knew there were other plan B. So see, guys, what he's trying to say is no money in the house. There are so many other people, philanthropists, trusts, everything that's there, but you have to find the right place and do the right things to get there. Don't give up.
The most important thing is, I always talk about, if you look at the drive, if you have the drive, you need to have that spark and drive and the goal and ambition. I think somehow you're going to achieve. The question is, how you put this drive into practice, You look for opportunities. That's one of the things.
One
the-
door closes, other door opens.
Exactly. I mean, there is always a reason why it prepares you for something bigger.
That's interesting.
Yeah.
Very
So
true.
when we struggle, the struggle teaches you something. That's what I always felt all along my life. And needless to say, during my final year of medical school, my father was in heart failure. He was in very bad situation. He had the heart failure we just talked about. He was fluid filled, and he was struggling on one side. And my
In your final year MBBS.
final year MBBS, my brother and brother's daughter, my niece, she has leukemia. She was in Kidwai, and she was going through blast crisis. So we had a very big crisis at home, and I have an exam. So it was how much can you concentrate to a level that you can get through the whole process. But luckily, I think by divine grace, it went through okay, except I lost my niece on the very first day of her internship. First day of her internship.
How old
Yeah.
was she?
6.
Ayyo, papa.
Yeah. It was
Blood cancer.
she had a blood leukemia. Yeah, blood cancer. And then subsequently, my journey continued on, and there were many people, including my mother's aunt, who was actually took care of my mother when she was in college in Bangalore, and she was a person who actually had some savings that gave it to my mother. That was one of my mother said, well, it is not my personal use, it's for yours education. So that was one of the things actually drove me towards, okay, how do you achieve what you want to achieve? You can do it here, you can do it somewhere else. I was never even thought about going abroad at that moment. I was thinking whatever I can want to do it well. And then that drive continued on, and many people supported. Somehow it paved my way into going into United States.
I think it was to be.
It was to be, yeah.
It was to be.
Yeah.
I know what all you have achieved. I think it was to be.
Yeah. There is something, as I said, the struggle and difficulties comes with some sort of determination. That determination also gives a drive to achieve towards what you want to achieve in life. I think that's happened. And, I never, one of the things I never give up. That is one of the things I never wanted to give up. And that principle still exists in me. And people always say, well, if he sees a patient, one of the things he tends to do, he's very optimistic, even despite there is a lot of pessimism happening for many reasons. And I take my patient, the longest case that I've done, what we call as a VT ablation, which is a very complex ablation, back in September of 2019, is a patient, a 53-year-old. He had heart failure, bad heart failure, not a coronary artery disease issue, and he had 20 different ventricular arrhythmias happened.
What? How do you pick
I
that up?
mapped them, 20 of them during the time. It took about 14-hour procedure.
My goodness.
Okay. So
you must be crazy.
Yeah, I never, even
So map you took 14 hours.
Map and ablate.
Oh, you are doing it at the same time.
Yeah, you go on the surface on the beneath the sternum, in the pericardial space, in the outside of the heart, inside of the heart, everything possible.
Wow.
So,
but so every time you're ablating, you're changing, it becomes normal, doesn't become normal, something else is
something else is coming on.
Constantly chase it until
everything is done.
Got it.
So that patient, the biggest, I never gave up. That's one of the things, and I continued on and then finished it. And at the end of the day, the next day when I saw this patient, when he woke up, he said he was so thankful for everything done. And this patient remained extremely well until just recently. I've seen him and he stopped seeing me because he's doing well. So that gives you one example to remember what really makes your drive to take you where you want to be. And needless to say, some of the complex rhythm problems when I face, where we tend to normally, especially when you're tired, when it is difficult, you may give up. But my interests are always not to give up. Okay, I will do whatever best I can, in my capability. So I think that's what is the drive which makes me feel, I think at least I want to contribute something so that they actually.
What I'm hearing, Venkat, is your mother didn't give up. Your father didn't give up. Your auntie didn't give up. So many people didn't give up on you. Correct?
Correct.
And because they did not give up on you, you could do, what you could do.
Mhm.
And it's but fair that you have internalized this whole thing, that you are now giving it back. It's actually paying a tribute to all these people who didn't give up on you. Don't you think so?
That's absolutely right. No, I must say this one. My siblings, same thing. They're each and
How
every
many
one
of
of
you are
them.
there? How many brothers,
Um,
sisters?
we were two brothers and two sisters for me. All of them are older, and the oldest brother passed away in 2008. And and our older sister, she passed away just before pandemic. She was mentally challenged. And then the another older brother and older sister, they're alive. They're doing well. And
They're in Bangalore?
one is in Bangalore, one is in United States.
Hmm.
So they all were driving force. I remember
Like
that
a
in school,
cheerleaders
yeah,
for
in
you.
the school days, it says, okay, I'm getting ready, I'm studying until the last minute.
Mm.
One is helping me with bag, putting the books. Another one is combing my hair and things like that.
Can you
It's
imagine?
funny. They looking at now, look like I
Entire
was
family,
treated
yeah.
royally in a way. It's my only duty is to work hard, okay, in a way. So that motivation continued on in my life, where I think I'm thankful to everybody. Needless to say, all the teachers in many, at every level.
We'll come back to the teacher. See, Venkat, I know how how successful and how big he has achieved in this arrhythmia space. He travels a lot apart from all that he does. He just came back from Japan, Tokyo to Singapore to here. He's landed 1 a.m. today. And look at this guy here to shoot the podcast at my request. So that is the drive that he has. There are enough people say, I mean, try this one there. I can't do that. My brain is not working, or something else is not working. But that's the way it is, guys. Remember one thing, don't forget where you came from and what you did. So, Venkat, coming back to, you had so many teachers and mentors and all of that thing. Before I go to that, you said you first were interested after you went to the US was to do oncology. And then suddenly you changed track, and then you did another change track in cardiologist. Tell us about that.
Yeah, that's actually very nice journey. So the first thing, anybody when they experience particularly something in their family or in the personal life, you at the younger age you think, okay, you know what, I need to do something. So this happened because of my niece. The oncology thing came because of my niece, and
And the helplessness and hopelessness
helplessness. Yeah,
that you
maybe
felt.
maybe it is a motivation for somebody,
Correct. Yeah, a
which
lot of people I've heard.
drives them to what they really want to achieve. So the oncology, that's how it started. And I had an eminent, hematologist, Gordon McLaren. He's a world authority in iron overload disorders. So I worked with him and did some research with him, and we presented in many international conferences. So he was driving me also. It's like, you have this
Correct.
teacher mentor and the student
Correct. Guru
relationship,
Shishya relationship.
guru
Yeah.
shishya relationship, which drives you to that angle. Then I interviewed all over the places, and a guy signed up an oncology. What really somehow turned me off was,
So you joined the program.
I almost joined because I
Almost.
signed the contract
Uh,
and everything, and about to start. And I was sitting in one of the, um, I went for a second time to see the program, and I was sitting, and one of the interviewing faculty was very upset that day, and he was somehow talking to somebody loudly, and then I asked the secretary what happened. So he lost 7 patients in the last week, and he's very upset because of that reason, which is rightfully so. And then it somehow made me think, would I be so much helpless at that time, or less hopeful? Maybe I think my hope, that is the only hope I think I would say possibly it suffered for a reason, I think. Um, then I said, well, could that, will I be like this, hopeless in my, cannot offer what I want to really offer? Because oncology at that stage was a lot different. 25 years ago, 30 years ago, say, it's a lot different than what it is today. Okay. And then that's how I was pursuing at that moment. And it so happened, my father was also on the balance with the heart failure issue. The
Correct.
cardiology was in the background, going on, motivating. And that's when I think I kind of jumped into the cardiology side. But this could be other reason why today I'm in doing all this, what I'm doing. is because there is a path. Everything I think happens for a reason. Yeah, and I strongly feel I think the destiny is kind of written in a way. But the question is, how do you use your understand what your destiny is, where you take it that way? It all depends on not giving up. In my mind, I think it's a question of I think pursuing towards your destiny.
Since you said destiny, not giving up, and it's probably to be. I have a astrologer friend called Dr. Purnima Bhatt, who is a Ayurvedic doctor. She says, Sharan, ನೀನ್ ಕುಂಡ್ಲಿ ನೋಡಿದ್ರೆ everything is here. Means all whatever you're doing is drama. It's already decided that you're going to go in this direction. You don't know about it, so you
That's
are
it.
thinking that you did all of these things, but there's something going on already which is scripted and things like that. So, since you mentioned that, how religious or spiritual are you? How has this practice impacted you? In this space, are you only science, or there's something beyond
Yeah,
science?
I think we need to understand for one thing we are not definitely masters of everything. That's for sure.
I agree.
So we yesterday's evidence is today's not an evidence.
Correct.
So we are so much fluctuating in our own thoughts.
Correct.
And
And
one
one
thing
plus one is never two in medicine anyway.
exactly. And if that is happening, so we are never masters. But there is one master is always there. That master is higher up. So if you do believe strongly in that way, I think that also brings out humility. Not only the humility, but also a nicer spiritual path. Yeah, I believe in this way. Okay, religious, staunch religious, not staunch religion, as a more importantly, use the spirituality part of the religion and bring that what we have learned this in the Sanatana Dharma into a practice is a good thing. One thing I always do, whenever I take up a procedure, I before I actually get to the cath lab, I silently do the, little prayers and meditation. For me, one thing is I always think about, I am an instrument, you are the doer. I mean, I want you to do through my hands as best as we can so that we actually offer what best for the patient at the end of the day. So it also brings me down. Okay, if there is somebody suggests something, which in the group we are a team of people. Somebody is watching something, somebody looks at it something. My fellow trainee is doing something and finds out something which I didn't pick up. So I will
And could
pay
have been a
attention.
critical point in that whole
Critical
process.
point.
Yeah.
I pay attention to everything. So my mapper, we have a mappers who come from different companies. When we're doing a procedure, they also pick up some very amazing thing. Then I said, well, and that's extremely everything. I think is somewhat intertwined with the sense of having this open to the idea of being the case.
I'm glad I heard that from you, because even as I'm scrubbing for the case, I'm praying.
Mm-hmm.
I'm praying to give me focus, give me the clarity to deal with some breakdown that can potentially happen, and so on and so forth, so that we do the best for our patients. And that's what all of us want at the end of the day, to the best we can. His destiny is going to determine whether everybody is going to survive, not survive. We know that it's not in our hands at all whether to live or not to live. So, well said. So, coming back to your cardiology, you chose cardiology and then you were neck deep into cardiology, and you told me a statement. You were working 8 days a week and you were burning out and all of those things. So, where were you manufacturing the extra time from, and what was going on in your life
Right.
at that time?
I think one of my very good motivator in cardiology fellowship was Les Miller. Okay. Les Miller was my program director and chief of cardiology at University of Minnesota.
And he is very famous for something, no? You were
Yeah,
saying?
he was, if you have seen what we call left ventricular, the LVAD program, the ventricular assist device. The first time in the New England Journal paper, we call it rematch study. He was so kind. As I'm a fellow working with him, he made me co-investigator in his trial. And then
You have been very lucky, yeah? You
yeah,
worked
very
with some of the best of the best.
best of the best.
I
Yeah.
think so.
So
That's not a kundal notification. It is all there in that.
it is all there.
Yeah.
No, he was. He almost treated he's like his own son almost. He was such a amazing human being. His work ethics, another thing. He used to call me cat because I'm a Venkata. So he used to call me cat. So 10:30 in the night, I came home after all the days of work, extremely busy day, very sick patients, and then cat. There is a transplant. So
What?
pack up and go again to the hospital. So
Rama
so
Chandra.
heart transplants is VADs and heart transplants were pretty big in University of Minnesota. So this was not uncommon. It came to a point. The 6 months in a row, I worked extremely, out of completely passion. It's not like, as considered as a hard work. To a point, I didn't realize I was getting a little burnt out in a way. It may be a good reason, but I burnt out in a way with respect to doing a heart failure transplant, which I thought I was going to do heart failure transplant at that moment. And David Bendit was slowly poking in my heart as for the heart
Everybody is
rhythm.
pulling.
Heart rhythm, he had this instilled a lot of knowledge and interests. So that was constantly kind of in the background was going on. So every time you sit and
Everybody's putting a
exactly, they're
worm in your
seeding,
brain.
they're putting a tiny
See,
seed. The one thing which realizes is okay, you know what? When you talk
they
about
should have made 3 Venkats. One Venkat goes here, one Venkat goes there.
maybe I
you.
think I almost thought that I want to do everything at one point. It's not possible.
Correct.
You
not
have to
possible.
focus on something.
Yeah, you have to give up something to
Give
get
up,
some.
to
Which is
gain
what I
something.
also have to do. Yeah.
Then the rhythm, I always felt one thing comfortable about rhythm is I question myself. Okay, you know what? 10 years from down the road, if I'm in a very difficult situation, I'm extremely tired. Do I feel comfortable doing this particular one? So it's not only just my own comfort. My comfort also translates into what I can do for a patient.
Correct. Absolutely.
So
directly.
Then I said, well, heart rhythm never bored me and never felt like I was tired. So then I said, well, I think that may be my field to take up. And Bendit was
Waiting.
was successful in
Put
dragging
the
me into
lasso
that
and
field.
pulled you in.
Yeah, I was a chief fellow. The 2 chief fellows actually came through at the time. They picked 2 chief fellows during the program. Chief fellow at the University of Minnesota. Then I disappointed Les Miller. I always feel bad about that because he was such a wonderful man. But he's still a mentor. I always think him. He was always taught me. And Bendit gave me the opportunity to go. And the 2 chief fellows end up being electrophysiologists. So among all the fellows that we go through the training, that was a big change actually, dramatic difference. Both of them.
Oh, you were the first 2 guys who went in that direction.
And no, as chief fellows.
That's
Yes,
chief
signed
fellows.
up both of them.
That's what.
In that direction. Yeah. And then I continued on, and at that time there was not much. Once again, you talk about, what do you disrupt, how you bring up all these newer ideas and thoughts. At that time the complex ablations were not very common being done.
Ablation. He's using the word ablation. Ablation is burning. I burn circuits in the brain. He burns circuits in the heart. So that's why we have a lot of things in common. That's why we are sitting here, doing that. We are brain circuit burning experts. So that's called ablation. That's an alternate to putting a pacemaker in the brain.
That's
so
right.
We'll talk about that, but now you can continue ablation.
Absolutely. So, basically what is happening, there is some short circuits or bad rhythms happening because of a focal activity which is triggering and, firing constantly. Or
Tarle circuit. I call it a Tarle circuit.
Yeah, circuit.
Misbehaving circuit.
Misbehaving circuit. Or it could be making a false loops around. So you need to interrupt them. That's when you use different forms of energy. And the energy which is commonly used for many years is radio frequency. Now there is another energy called pulse field ablation has come. Talking about those complex ablations, it was not very common. There are very few centers in the nation they were doing at that time.
Which time are you talking about?
This is back in early 2000s. Yeah. So then I said, well, I should make sure that I learn this one. Okay. So there's no specific training programs you go through, like, complex, advanced, a fellowship program or something like that. So I said, well, I'm fortunate to say that one of my greatest colleagues, Dr. Jimmy Lee, sadly he passed away. He was a great friend, almost he called me brother, and he said, you should go do it. I will take care of the family. I've got a very big family, very big family. Amazing. I will take care of the service. You go do the sabbatical. Oh. So I ended up doing sabbatical at UCLA. When I went to do the UCLA sabbatical, and Shiv Kumar is a energy source of energy. He's like he's abundant amount of energy.
That's where you met Shiv Kumar.
Yeah, I met Shiv Kumar. Yeah, he was the one. I wrote to him. I want to do something like this. He said, with open arms, he actually invited me. So I did sabbatical with him. Not only that, I ended up learning many new techniques and things like that from him. But also at the same time, there was several mentors came there during that time. Kenneth Ellen Bogan, who was a former Heart Rhythm Society president, and then Fred Muradi, who's like another genius in cardiac electrophysiology. All of them came there.
See, guys, what he's trying to say is once you become expert, it's, oh, I'm the expert, I'm the greatest, I'm God. I feel it's not like that. All of us keep on coming, meeting, exchanging notes, because the more we know that we don't know. And that's the beauty of being humble. And I'm going to pick his brain on that. Continue, Vivek.
Then I was fortunate actually during that time.
Amazing.
They all
Timing,
came.
Timing.
What a timing,
Timing.
And then learned a lot. Then came back to
What
Minnesota.
you learn from the no textbook will tell you.
No textbook
Alva?
will tell you.
Nothing,
No,
because those
yeah.
wisdoms will never get.
Yeah. Then after coming back to Minnesota, I started the program. To a point, it grew very well. It's all teams work. It's not just me alone doing anyway. It was a team's work, and all my trainees came through the program, also did very well, and some of my trainees are doing extremely very well. They become top leaders as well. So that actually makes me feel even happier. It's just not like disseminating the knowledge what I learned or what I experienced, so that I can give it to patients, but also give it to my
because
fellow
so many
trainees.
people invested on making you who you are today.
Yeah.
And if you do not invest that back to give it to the next generation or next thing, then you're being selfish and greedy and whatever else it is. So this is one of the biggest things I learned from Venkat, and both of us agree that the more you give, the more you get, and you have to give back to. That's how we've had selfless mentors who taught everything that they knew and even more. And probably that's Dr. Narendra also always used to me. Dr. Narendra is one of the podcasts you could please go back and see. He said the student is always better than the teacher, because he's sitting on top of the shoulder of the teacher, so he can see farther than the teacher.
Absolutely.
And that's such a powerful statement. Yes,
I think there's much philosophy hidden inside.
Absolutely.
Yeah.
Absolutely.
So I think it definitely, they'll open up sometimes. The questions actually open up.
Yes.
You don't think necessarily like the way that I would.
And it's never linear. It's always non-linear learning. It goes all over the place, and then that learning is at the back of your brain. And suddenly in a crisis situation, boop, 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 everything comes in front of you, and you've got all the tools in your toolkit required to fix it, or modify it and fix it. So I think we spoke enough of a deviation. Let's go back to the hardcore stuff that you were talking about. You did 14 ablations, you got into arrhythmia. So that now understand, guys. He's gone through whatever. Now he's an arrhythmiologist, and now he's burning circuits in the brain. He's innovating. He's trying to contribute new stuff. And that's when I want to pick your brain about, what are you ablating? How is that procedure happening? Can you just give them a little bit of a procedure? How does it
Absolutely.
I put a frame, I do this, and I have my own procedure. How does it work for you?
Yeah.
Do you use a cath lab, or where do you do all these things from?
So this is all done in the cardiac catheterization lab. We call it EP lab. It's the same thing, and the setup is a little bit different. So there's one thing is you have X-rays available. These days we are becoming more and more fluoroless, which is very nice. Yeah.
Fluoroless?
Yeah, fluoroless.
Then what imaging are you using?
So what we use as intercardiac echo, which is echocardiogram inside the heart. We have a tiny catheter goes inside the heart. We can actually do an echo inside of the heart. Then we use.
But you do from a femoral puncture or radial puncture?
Femoral, all are femoral. And some of them actually I go just beneath the sternum.
Oh, straight?
Yeah, straight, actually around the heart.
Okay,
on the surface of the heart.
Direct puncture
and the pericardium, within the pericardium.
I see.
Pericardium is the sac which actually the heart sits inside that sac, and the heart is moving, and there is a fluid around that in that sac, like lubrication. So you use that sac to move the catheters around. It's a free space. But it's also limited by coronary arteries, which is on the surface of the heart, where you want to do anything. But it gives an opportunity to look at some arrhythmias which can be tackled that location. But most of them happens inside of the heart. So how do you go through femoral vein, which is a big fat vein in the both groins.
So more of a vein catheterization.
Vein, most of them are vein. I don't necessarily need to use the artery.
See, I didn't know this.
Yeah.
Okay.
So, I avoid artery if we can, because arterial access and complications are higher risk. So we minimize the risk. And the most of the arrhythmias, I tend to do complex ones are in the top left chamber, or the most bottom chamber in the left side, left ventricle. So I do go into the top right chamber. There is a wall which divides between the two top chambers. There's a little dimple. Embryologically, that's a hole which the oxygenated blood from mother goes across, to the left side because lungs are not active as a fetus.
When
And
the inside,
that
yeah.
flap is closes, it then becomes membrane. And 20% of the people walking in the street may have a tiny hole still. So we
And what is the
use,
tiny hole called?
this is the patent foramen ovale.
PDA. Yeah.
Yeah,
PDF,
foramen, no,
PDF.
yeah, foramen, PFO. Okay.
PFO, sorry.
Then the fossa is the fossa is the one which you actually puncture. We puncture with a little wire these days, radio frequency energy, tiny wire, which goes to the left
So
side
you
of the
burn
heart,
and go through.
go across, and then you gain an access with the sheath. So you're in the left atrium. So all the left atrial procedures are done like that. Then I actually go through the mitral valve into the ventricle. Yeah, that way. So we use multipolar catheters. These catheters are, just to give you a background, in 2004 when you map the ventricle, you take 400 points and the system used to freeze. Now you can take 60,000 points.
Wow.
Yeah, there's a big difference, is that right?
Technology, how much technology has
changed.
helped us, huh?
Yeah, and it can not only identify what we call as a voltage mapping. Voltage mapping is actually it converts this, the scar area, the voltage is less, living area voltage is more, and there is gradation in the voltage, channels, and slow conduction. Everything can be picked up.
Everything can be picked up, huh?
And one sweep, it automatically
So
picks up
you are
everything.
in the ventricular chamber and picking it up, or you have to actually go into the muscle to pick
No,
it up?
in the chamber,
The chamber.
right on the surface of the heart.
Oh, that's
You
enough.
place it. That's enough to pick up all the signals.
Wow. How does it pick up? Just
Um,
for my technical
so
understanding.
the catheter is a multipolar catheter. It sits on the surface, inside the surface of the heart, and the electrical signals, whatever it's coming, is picking up. You can see in our recording system and also mapping system. We use a different types of mapping system. That mapping system converts these signals into color-coded maps. Okay.
It interprets also for you, or it just
Now, some of them, it gives some idea. Then you actually adjust the scale. There is a mapper who actually also helps us in the real time.
that's the mapper you are talking
the
about.
mapper we were talking about. And
So he's the logic. He's giving you
yeah,
some
yeah,
observation
absolutely.
logic.
And there's so much atomized these days. It actually still picks up a lot of interesting ones. And you can actually use specific beats, and you can tag them, and you can do what you call a turbo map. Let's say if I'm mapping certain thing, it rapidly maps back whatever you want to map, whatever you collected. So it's like a bank. Everything is there. You can actually
Like an AI, some kind of an AI that's kicked in.
You can tweak it how you want to do it.
Amazing. So you got data. So you're doing this scan. You got the data from there.
You got that.
Based on that, you made some decisions.
Yeah, make that. If it's a reentrant loop going in the circuit, then you need to interrupt that area where it is taking a channel through a scar, for instance. Then you go use a radio frequency energy, ablate that one, and terminate that rhythm. Or sometimes you may have to.
So you're burning. What temperature? What are you using to burn?
We used to use temperature based catheter ablation technique. Nowadays we use power based. So
what do you mean by power based?
Power based, it uses power as how much power you can drive, or how much current you can drive within the muscle wall.
So power is drive. Amperes of current, right?
It's actually amperes of current you can actually drive. So the power, it gives us X number of watts. For example, I want to do 35 watts to 40 watts or 50 watts of power. We can give up to that one. Ventricle needs a little bit more.
Okay.
Then it actually, you look at the impedance,
2 watts, 4 watts.
How much impedance you drop, how much impedance, then you know how much you're delivering the energy. This is radio frequency. The new thing which is on the horizon, new kid on the horizon, is the pulse field ablation.
You were telling me that.
Yeah, that is not an impedance-based system. It is a field-based system. And we actually give about 2000 volts of energy.
What?
Very high energy.
But as a like a laser focus.
Yeah. Right? So that gives, that actually kind of shuts the electrogram off.
But it doesn't go further? It doesn't penetrate further?
It's an amazing thing is the muscle wall architecture is maintained.
Really?
Very well, yeah. It is we call it as a non-thermal, because only reason is the temperature doesn't rise up.
So it doesn't dissipate, doesn't go beyond what you're shooting.
Yeah. It depends on the catheter footprint. Then it creates that block of, we call it electroporation. It actually causes the disruption of the cell membrane.
So you can modulate the size and everything else. You can pre-do that and then shoot?
You could do that, yeah. You could do that. then it causes apoptosis, cellular apoptosis. It does the same thing what the ablation does, except, and it also, so far,
The funda is the same, but the
we
science
just
is different.
I was a part of the big manifest PFUS registry. We have 45,000 patients, which was presented just last week.
Ooh, 45,000.
1,000
Just from the
patients.
US or globally?
From the US, just the US.
ಅಷ್ಟು ಜನ ಇದಾರಾ?
Yeah, that
Patients,
many
sir.
ablations. This is
Huh?
for atrial fibrillation we did.
I agree.
Okay.
It's a serious
And
number.
it was led by one of the.
How many years?
This is the last year and a half or something.
ಅಷ್ಟೇ?
Yeah.
Whoa, that's a
Yeah.
serious number.
It's becoming a huge thing. This is for atrial fibrillation. And the safety and efficacy, both we have looked at it. Efficacy is similar to radio frequency energy, but the safety part was also extremely good. No collateral damages, super low, if at all anything. And I would say probably not much at all collateral damage. Radio frequency energy causes heat to dissipate.
Correct.
So it can cause collateral damage. In this case, it doesn't cause collateral damage. The structure is around the heart. So it's coming to the ventricle. As soon as I go back next month, when I have compassionate grounds, it is not approved in the ventricle yet by the FDA. The FDA actually given me permission to use for 2 patients.
You're a big
There is
man.
separate catheters to use, so we'll be doing those.
You see, a
Yes.
guy who was looking at scholarship to pass his MBBS, he's now getting funds to do, breakthrough work so that thousands of patients can be saved by these things. Venkat, hats off to you for your drive. I can see, I can hear that drive. It's amazing what you have done. I'm so happy.
You're too kind.
And to give this episode is coming out on the World Pulse Day, the World Arrhythmia Day, in that time. So it's but appropriate for you to do what you're doing. So now an automatic next question is coming to my mind. So very early in the podcast, you spoke about the pacemaker, the wired, the wireless, and all of those kind of stuff. Now you're talking about ablation. So, but they're all both treating the some kind of a rhythm problem in the heart. Now, for the ease of from our patients or people to understand, if a patient comes in on top, who goes here, who goes here, how does that triaging happen, and how does the decision making happen? I'm not expecting them to take this and go, but just as a directional thing, how would somebody like?
No, very good question. Actually, good to know, because so much abundant amount of information you need to figure out. So it could be an interplay. Both of them can be an interplay. So when we talk about pacemakers, let's take pacemakers into as a first topic. Typically, common reason why you do is a slow heart rhythm. Okay, slow symptomatic heart rhythm. It could be
the heart blocks that you spoke
heart blocks, or it could be extremely slow top chamber rhythm, and top chamber which is not driving. In that situation, you use a pacemaker. Okay, the pacemaker basically does the function of what the natural conduction system was doing it otherwise. So next comes defibrillator. Defibrillator is treating a very serious ventricular arrhythmia. We talked about it's a saver. It's like having you've seen in all the movies, they use the paddles to shock the patient out when they go into a serious arrhythmia. In that situation, the defibrillator does the same. Michel Moravsky was the first person who actually thought about implanting that kind of a device. And when he showed
guys, the shock on the heart that on the chest we keep is called a defibrillator. The action that we do, he's talking about defibrillator putting inside the heart, which this man did.
Correct. So typically, what happens, there is a lead similar to pacemaker, but it's got a coil there.
Okay.
So it creates one pole, and then there is a tip which actually senses, and it senses what's happening in the heart. If the bad rhythm starts, that it senses. There is many algorithms written, because it actually tries to look for the native rhythm, how the morphology looks different, or the same thing, or it could be even the rate. Then the battery.
It's learning itself, or
it's learning itself. It's constantly learning. It's pre-programmed and also constantly.
Baseline. Okay,
yeah.
It's a combination of both.
Combination of both. And then there is the battery also has got the brain behind everything. Okay. So that goes beneath the skin, which is that is the defibrillator basically. So it can deliver a shock to get the patient out of this rhythm. So it is the early defibrillation has been known to improve survival. We all know that. So it improves the survival. The next thing it can also do is it can actually, without even shocking, some rhythms can be terminated by pacing faster than the rhythm itself.
Oh, so it paces also. So it's not just a defibrillator.
It's a combination. It's a dual. Pacemaker, defibrillator. Okay. It's capable of doing both.
Interesting. So how do you decide? Now is going to the next question. How do you decide who needs only a pacemaker or pacemaker from defibrillator? How does that decision making
Yeah.
happen?
So typically for a pacemaker, the heart function needs to be normal. One reason. There is no indication for a defibrillator. For instance, patient survived because of a cardiac arrest, or patient's heart squeezing function, or the ejection fraction we talked about is less than 35%. If you don't have all those, you could put a pacemaker. Then
But you do a 1 week of Holter to sort out all those things, and then you do that.
you may or may not need. Depends on what you need. Your indication is what you're looking for. Then, as far as the defibrillator itself is concerned, these are the survivors of cardiac arrest, and they don't need a pacing function. Even if they need a pacing function, this is fully capable of doing pacemaker function as well. So, in that situation, you can still use them. There is a third set of devices, which is kind of a little bit modified version of defibrillator called cardiac resynchronization therapy. So, where if the heart is desynchronously contracting, then in that situation, you can actually place two leads in the ventricle. One goes to the right ventricle, another one goes on the tiny vein on the surface of the left side of the heart, and then one in the top chamber of the heart.
Now, how are you accessing all this? From the puncture here?
No, actually, we go through the axillary vein.
Axillary vein.
Yeah, axillary vein
And
over
then
the
how are you imaging how to reach the end point? Doing it on the cath or
through the fluoroscopy.
through fluoroscopy?
Yeah, this is all fluoroscopy based.
Got it.
So then these all also can be monitored remotely. We have a lot of remote monitoring system, and it can actually
Remote means
transmit.
patient is somewhere and you are somewhere, and the data is coming to you.
Data comes to you.
Whoa. Wi-Fi enabled?
Yeah, Wi-Fi enabled. It can actually transmit. Some of them are they have innate cellular capabilities. So many
Can
things.
can you distally reprogram that thing in case of a crisis?
Distally, you
Or
cannot
is it only
reprogram at this moment. There are many reasons for it. It's like much more logically difficult ones, because if somebody hacks onto a something system. Right now, I think that's not something in the purview, but it is. In the clinic, they can be done as a Bluetooth. You don't need to even. Actually we gain the function.
We have a
you do
similar
the
thing
fit.
programmed
Yeah.
for our pacemakers in the
Correct.
brain.
Very simple. And as far as ablation tree goes, we talk about ablation earlier. Those are the ones, once you determine, okay, the patient has a defibrillator, now getting multiple defibrillator shocks. So you need to stop the shocks. You tried medications, it may not work. Then in that situation, you have to take them to the cath lab and do the mapping, find the circuits, ablate them, get rid of them. Now, sometimes,
because it makes no sense keeping it. It's
and also the survival improves by doing an ablation. Although the survival studies are difficult to do them, but overall, I was part of the International VT Center Collaborative Group. Initially started as 1.0 version, about 12 centers across the nation. We had across the world actually. We had about, and we were one of the centers. We actually collected little more than 2,000 patients, looked at them, and then we found that the patients who survived, getting through this ablation, this transplant-free survival was extremely good compared to patients who didn't have the ablation. So that was one of the things, and there are many studies which actually kind of tend to trend towards the survival benefit. A survival benefit, if you want to really do a survival study, it's not ethically correct or possible to do it. So that's where it is. Overall, I think the techniques have become so good. So it does make definitely a significant dent on what we are doing.
I think these are all quality of life issues, more than anything else. So coming back to what you said, so what I heard, I don't know whether I heard it right. You're saying that you may put in an intracardiac defibrillator, and if you see this guy is constantly requiring a lot of defibrillating, treatments, therapies going on even with the machine, then you feel that's not the smart way of doing it, and you want to ablate it to stop this whole thing. So in spite of having an intracardiac pacemaker, you can still go and ablate it. It will not harm the system.
It doesn't harm the system.
It doesn't go back and short circuit or none of those things.
None of those.
They're all designed to do that.
Correct.
Excellent. So
all these patients have this, but the defibrillator is still available as a backup.
I understand.
That's a great thing about that.
Yeah, I agree. So you can still have a backup. That's even if you can reduce it 50%, 70%,
it's huge. It's huge.
Absolutely.
Yeah. In fact, there was one patient I flew into Kerala to do several years ago. The new syndrome called Brugada syndrome, which is not It's actually Southeast Asian population is more common. For some reason, there's some clusters in Kerala. And the young patient, 33 or something like that, his age, he had about 59 shocks or something happened. Defibrillator shocks. The defibrillator almost depleted battery, that much
The
amount of shock.
intracardiac defibrillator.
Yeah. And then we actually did an ablation for this, which was very early, very early in the stages when we did that. It was a dramatic change. It went from there to eventually zero. It was very, very good. So those are the life-changing for these patients.
Amazing.
Yeah. So the other one for the ablation part is the so-called the benign rhythm, supraventricular arrhythmias are also very good rhythms to ablate. The success rates can be as high as 99%. The risk is less than 1%. So for all these procedures, one thing we always do, I think we kind of previously talked about it, is we talk about this patient risks, benefits, and the what are the alternatives for these patients. Sometimes alternatives will be very bad. So you have to choose what is the best of the two evils, is that right? So in that situation, quality of life to many things, it actually improves. Overall, I think we could provide a very good solution for this.
So what Dr. Venkat is saying about a lot of our patients ask us, is 100% success, 100% guarantee, and things like that. Nothing is 100% guaranteed. I tell my patients, nothing is 100% guaranteed except you're going to die one day.
Yeah.
That's 100% guarantee. The question is, as long as you're alive, what is the quality of your life? The reality is, whatever has happened because of which you're sitting in front of us. Now, what we are offering, is it lesser risky than what you're already going through? Is it going to prolong the quality of life with the lesser risk? And that's the risk-benefit ratio that we have to weigh each of you. Risk and benefit of doing, risk and benefit of not doing. And then I think that will automatically answer the many questions rather than looking at absolute values of, the yes or no. It's not binary at the end of the day.
Totally.
It's
totally.
not binary at all at the end of the day. So that's a very interesting. So you sort of covered the whole thing. And you already touched upon the defibrillator, in both ways. So I think we should dedicate a little bit of time to the AED and the defibrillator itself as an independent entity. So can you educate our people about the whole science of defibrillation and the simplest defibrillation? You spoke two ends already. Can you just give us a little bit more organized commentary on that?
Now, before I even step into that one, one thing I wanted to say is somebody has a cardiac arrest, in a public area, for instance. I think one thing we need to do is to give attention how quickly you can actually try to resuscitate. I think Dr. Yash Lokhandwala from Bombay has taken a big initiative. Recently, he's an electrophysiologist. The initiative, what he has done is he involved some of the celebrities to actually promote the idea of CPR. Okay, you may think, okay, what is CPR is about? So American Heart Association released long time ago. If you do pump fast and pump quickly, that means as soon as somebody goes down, collapses, see them, ask them, are you okay? If the patient is not doing okay, not responsive, first thing to do, call somebody, okay, call the emergency services, and don't accumulate and keep looking. The first thing to do, keep them on a hard surface and position them, learn how to do CPR. And if you pump fast, 100 to 120 beats per minute, the faster the better, because the brain needs blood supply. If you stop the brain dead, nothing can be achieved. So, and the heart also accumulates what we call as a lactic acid at some point, then it becomes irreversible. So you have to keep moving very quickly, and the coronaries need to be perfused. So when you do that as a first step, you will improve survival for many people. Next comes the defibrillators.
You also spoke before you go to. You also said how much of depression that has to go.
It's typically what we describe as 1.5 to 2 centimeters of depression of the sternum or the breastbone. So you need to hold and keep it straight, and then you need use your shoulders to actually pump the.
You can see Dr. Basuraj's episode that we have done the CPR program already. So you can watch Dr. Basuraj's episode, Life and Death, and then you'll get that.
In fact, I think one of the biggest things Ash is also suggesting is to bring this to at the school level, very early in the stages to learn. Everybody should go through. Everybody should be educated about this. So that's as simple as that. Then comes the defibrillator. Now the defibrillators, it used to be very expensive. The external defibrillator, automated external defibrillator,
AED. That's
AED.
You
Nowadays,
see the airport and
the
you know,
airport now they are putting everywhere, which is very good thing. I'm glad that they're doing it. What these defibrillators are, they do, which is very unique and good, is once you have this one, you open up, it'll actually, there is a voice guides you how to do it. It's as simple as that. So it'll ask you to put the patches in 2 different locations, and it automatically, you can continue doing CPR, and it'll ask you to pause to look at it, what the rhythm is. It says, okay, shockable rhythm, you clear, and you push the button, it charges and shocks the patient. If it's not shockable rhythm, it also tell you it is not a shockable rhythm. It analyzes on its own. So in that way, you don't
so
need
it's
to
not
look at
just
the
an
screen.
ECG, it's not just a defibrillator machine.
No,
It's
it's
much more
actually
than
much
that.
more.
Correct.
And it is becoming cheaper and cheaper. It's very well affordable. Many people tend to keep that in their homes.
That's what you told me.
Yeah.
That I've been thinking ever since you told me that a couple of days ago. Maybe I should start looking at that.
Yeah,
Interesting.
it's not bad at all, the idea, because it all depends on how quickly you access. Is that
Correct.
right?
I agree.
If you can
No,
access,
because we see so many patients. I'm sorry to butt in, is because you know that, like he said about the access of brain oxygen to the brain and the brain dead. We call it HIE, hypoxic ischemic encephalopathy, and many of such patients, you know, out of hospital cardiac arrest especially, are then coming to me for neuro rehabilitation. That's when we realize that if anything could have been done faster earlier, maybe the brain would have got salvaged.
absolutely, absolutely.
HIE.
Yeah, I think being aware that this is a possibility and acting quickly is the solution. The Minnesota has got a very interesting, important drive, I would say. Seattle and Minneapolis, the two cities, have done very well. What they have done is, we have at University of Minnesota, there is a big driver called Dimitris Hanopoulos. He's got a lot of NIH grant in this aspect. So what he has done, started out, is called the mobile ECMO. So the concept is, all the ambulances are equipped with ECMO.
ECMO?
Yes.
In ambulance?
Yes. So they are able to get the ECMO on site. They can get it so quickly. Put the cannula, get them.
Unbelievable. That means who is going with the ECMO?
They're people on call.
Huh?
They're
Really?
trained. They're able to do it. They get
They're more like a paramedic technician, or are the
no,
doctors?
it could be on call.
And he's sitting in the ambulance and going to wherever.
If there is a need like that. Yeah.
Amazing,
Yeah.
amazing.
Yeah.
So what's an ECMO? I mean, I know what's an ECMO.
Yeah.
Why don't you tell the
Yeah, the
ECMO?
expansion. Yeah.
ECMO.
Extracorporeal membrane oxygenation. Membrane oxygenation is basically for oxygenation of what we need for keeping the a brain, lungs, heart, everything, every organ needs an oxygenation. So extracorporeal means you are actually doing it's externally going through a membrane.
Yeah, outsourcing.
Outsourcing. You may or may not know, but Walton Lillehei was one of the cardiac surgeons, earliest cardiac surgeons, who was from University of Minnesota. Fortunate enough to say.
Really?
Yeah.
Minnesota, such a cold place. How do you land up in that place?
Everything started there.
Amazing.
So Walton
brain doesn't work at that temperature.
Yeah, Walton Lillehei was the first person who did the cardiopulmonary bypass.
Amazing.
So what he did was he used
again Minnesota.
He used another patient's own father. He connected with them to go like a circulation, because that person is alive, is pumping. That's how he got the idea of doing an external.
ECMO came from there, huh?
No, the cardiopulmonary bypass.
Bypass
ECMO,
came.
Of course, it came subsequently.
ECMO
very
is an
similar
extension
to
of that.
Extension of that.
Got it.
So Christian Bernard was his fellow.
Correct.
Who did the first
Christian
heart
Bernard was
transplant.
his fellow.
He was trained at University of Minnesota.
Oh,
And
amazing.
Shambe was the
you
first
were one of
person.
those.
Yeah, all these giants came from that location. So, so that's having that background. So the ECMO concept there is you provides a circulatory support, oxygenation circulatory support, and depending upon what the problem is, if it's a primarily lung issue, you can use what we call as a VV ECMO. We just give the oxygenation, the heart is functioning fine. If the heart is not the case, you do the arterial and the venous cannulation, and it does its job, in other words, and keeps this patient at least a bridge for next treatment, what you can actually do.
It helps you to buy time.
By time.
Correct.
Yeah. And it has got its own problems. It's not 100%. Nothing is 100% safe. Yeah. Now, you cannot walk outside 100% safe. So, same thing happens when you do anything too. Yeah. So, but
just to show you that so much is happening, so much is possible. The only thing is to make sure that, you reach the right hands at the right time for the right thing to be done. So amazing, amazing. So ECMO is another. So we spoke about the simple outside defibrillator, the shock, then going on to the AED, which is not in just a defibrillator. It's like a portable one. You can keep it in your house. It even instructs you what to do. It's having its own wisdom. It is telling you yes or no and all of those things. And then you're going to the intracardiac defibrillators, which is pre-programmed, and it's also doing AI. It's amazing what all is possible, to keep things going, It's incredible what is possible. So I think it's so much that you have told us. What else have you missed in talking about it? Anything that we have missed talking about?
I would say one aspect is innovation.
Correct.
Okay.
We
So
didn't spend enough time on
enough
that
time on
side.
that.
That side.
But I'll maybe a couple of sentences I wanted to
Sure.
say for the particularly upcoming people. So if the thing is, my passion started out, okay, what else can I do to keep myself not just stimulated in the academic side, is apart from the fact that I'm interested in teaching. I run trials, first in human studies, multiple things we have done, including ultra low energy defibrillation, all sorts of things. Is to do innovation if you can. Okay, it's actually slowly picking up in the younger audiences as well. And the things like Stanford University is very big in biodesign programs.
Correct.
Stanford Biodesign.
I know.
Yeah.
The Dr. Jagdish Chaturvedi, who again I've done a podcast with, who acted as my role in my web series called Beja and Fry. If you guys have not seen
Yes, I remember that.
Yeah,
one.
Beja and Fry web series on our life on YouTube. Please go and see on PRS Neurosciences. So he's an ENT surgeon. He was the first batch of guys from India, 4 of them or 5 of them, who went to do the biodesign program in Stanford. And then he came back and he started conducting those courses. And one of those I sort of got involved, and that's how we met, and things like that. So I understand this course quite well.
Absolutely. Recently, I spoke at. I was invited to speak on the Innovation Summit in the HRX, another very upcoming, very novel type of a Heart Rhythm Society launched, program. I mean, the convention where they're very interesting industry to engineers to physicians to scientists. Everybody comes together. Some of them are roundtable discussions, some of them are presentations. So I spoke on this innovation summit, and
Where was this?
This was in Atlanta.
Okay.
And then my chair of the section is Uday Kumar. Uday Kumar is a very interesting background, Harvard trained, and he went to UCSF. Took a break. He was born and brought up in America. Then took a break and did biodesign program. He teaches in biodesign now.
Oh.
And then
basically background was engineer or doctor?
He's a physician.
Physician.
Yeah, I think he has some background in engineering too.
Okay. But he also has a medical degree.
Correct. And then he became an electrophysiologist. Okay. Then he's the one who does what is called a Zeo patch, the new patch monitor. It's taken like a sweep across the country. Every hospital uses Zeo patch. It's something very simple.
What is that patch?
Simple patch monitor, keep on for 2 weeks.
You just stick it on there.
Stick it on there. It gives an ECG, analyzes the data. There are 2 different categories: continuous monitoring, somebody is monitoring, or otherwise it just collects if you think the patient is capable. You don't need to possibly monitor that closely. You want to just gather the data. Then
like a Holter.
Yeah, Holter. But very simple, cheaper, very elegant, clean signals. So he did that. It's become extremely. He is doing another very interesting called a Life Vest. Similar to Life Vest is another vest. It's like a T-shirt. It has got a defibrillation capability.
What?
Yeah.
Really?
In patients who are bridging for a defibrillator therapy, that kind of thing. He's working on that. Okay. So
are you serious?
Yes.
You just wear a T-shirt and there's a defibrillator.
Correct. It's crazy, isn't it?
Crazy.
Externally.
Crazy.
So I think
T-shirt lose out you should be careful about how it sticks into that.
No, the problem is there is a thing called Life Vest right now.
Okay.
It's not patients are not very using it very commonly because it's too bulky to wear, and they have to do shower, they take it out, and they can have an arrest during shower. Many reasons, anyway, the reason he brought up was innovation. So that innovation concept, he really did so much. There are many, many talented physicians like that. So with that in mind, I started to think, okay, what really helps to bring new ideas, is that right? Once you get onto this fever of innovation, that actually sets you think more. I think you think, one of my Oxford University professors used to say, very first time I wrote a paper, and he said, even if it's simple case report, when you write something, you learn something, your mind start thinking differently. So that is the stepping stone for you to become more innovative. So I think his statement is, even today I'm remembering, after 30 years is the reason, good reason, is because I think that teaches lesson at every moment. It's very valuable. So that led to all these things, and I'm working with many companies now developing new concepts, and we're bringing in new ideas, new trials, tools, and which actually improves the overall patient outcomes. I think being as a physician, not only driving in academics, doing something, you could actually disrupt the whole thing by getting into also innovation side.
I agree. You see, there's so much similarity to what both of us are doing, because I also believe I'm doing it myself. Innovation, disruption. That's what we are also trying to do in the neuroscience space, and that's why we keep getting along very well at that. That's why I want to pull him into this. But you see, guys, what is amazing for both of us is the more busier we are, the more time we have.
That's right.
We have time, and we are not doing all this for self glory. We are doing all this to help more and more patients. Please understand, we can sit in a corner, work X amount of time, and do 100 other things, probably play golf, relax and do that. And not that, and we are doing this because there's a passion, there's a purpose, there's a loss of vision. There's so many people who supported him, so many people who have done so many things for me, to make sure that we are in a space that we can impact large communities, and people who are suffering. And it could be somebody known to you. It could be your father, your mother, your brother, your sister. It could be anybody. So keep that. It's a selfless service. He's working in a government setup in US. Don't think he's working under Elon Musk and taking tons of money, $1 trillion, paycheck and things. So nothing like that. Venkat's, it's not the money which drives us, guys. It's the passion to make a difference, to save people's lives. And I think, Venkat, that's what I can clearly hear with you. I can see that, like me, you're signed up for a long time. You have no plan to give up or doing something. Oh, I'm, 40 years retirement, I'm doing none of those things. So you can see very, very clearly. So we are going to meet, continue to have these chats so much more. I think it was fantastic chat we had, My heart rhythm has come back to normal now. We kept going up and down. It was regular, irregular, all sorts of stuff. The song calmed it down for sure. So it was fantastic. So before I wind up with him, don't forget the housekeeping rules. Subscribe to our channels, YouTube channel, and the Instagram channel, Rebooting the Brain. Watch all our videos, subscribe, hit the like button, the bell icon, share it generously, and for sure, put your comments in. Venkat, I think it was a fantastic talk. You have given such a lucid clarity from a simple, normal ECG all the way to what the future is holding. And at every point, I could hear clearly it is patient first. Patient's interest in the middle of what you're doing. You're not talking about the dollars. You're not talking about the money. You're not talking about the royalty. You're not talking, for you, the royalty is the kick that you get when the patient has no arrhythmia and he's gone back to his life.
That's absolutely right.
And that, I think, guys, is the hallmark of a genuine world-class physician. If any medical students watching this, that's what I want you guys to ingrain. This is the skill sets you should get. Be a great human being, a great doctor, a great healer. Everything else will come, whether you want it or not. Correct, Venkat?
Yeah.
The name, fame, money, everything will come. But don't lose the focus from the primary thing. Is a patient who's crying for help and needs your help.
Absolutely.
Thank you very much.
Thank you
for this fantastic talk. And we'll definitely have more chats on this.
Thank you.
Thank you.
Thank you so much. Thank you so much.
So the last gesture, Venkat, is we always give a copy of our book to all our guests. So this is your copy. It's called Rebooting the Brain.
Thank you so much.
Please, it'll help you to reboot everybody's heart. So for sure.
No, this is phenomenal.
Yeah.
I really, I'm actually excited.
Please do give your feedback on
absolutely.
that. Thank you very much.
Thank
It's all
you.
yours.
Thank you. Thank you.